Good morning. Welcome to the CME lecture series organized by the Kandy Society of Medicine. As usual, we are having these weekly lectures. Now, although we are in a crisis situation in the country, having the COVID-19 pandemic, but we have decided to continue our CME series. Now, although the few number here, but there are many have already logged into our link, so they are listening to the lecture and watching the lecture outside, so that's good. So that's what you want. No need to ask everyone to come here, but they can make use of these services provided by the Kandy Society of Medicine. Without taking further, today's lecture is the current updates in resuscitation. It's a very important topic, and all the doctors practicing in the medicine in this country and in the world should know how to do resuscitation, and the basic knowledge is mandatory for each and every doctor to have it. So today the speaker is Dr. Buddhini Imbulpitiya, our MBBS, MD and MRCP, is our consultant intensivist at Ashton National Hospital, Kandy. So I invite Buddhini to start his lecture.
Thank you very much, sir. I'm very thankful to the Kandy Society of Medicine for inviting me to deliver this lecture, especially to Dr. MBBS for asking me to talk about resuscitation. So my topic today is on current updates in resuscitation. So in this talk, I'm going to go through mainly the European Resuscitation Council guidelines. And we are expecting a change in the guidelines in 2021. Even though the guidelines were supposed to be changed in 2020. So recently we had a Congress and there were draft guidelines published in October. So I have gone through those guidelines as well to talk to you about this update. And these European resuscitation guidelines are based on International Liaison Committee on Resuscitation, ILCO, 2020 Consensus on Science and Treatment Recommendations for ALS. So my objectives today are why it is important to learn commitment resuscitation and what we mean by chain of survival and how you approach to a deteriorating patient, basic life support, advanced life support algorithm, post-resuscitation care, and resuscitation in COVID-19. So I hope to cover this topic during next 60 minutes. So why is this important? As all of you all know, ischemic heart disease is the leading cause of death worldwide. And sudden cardiac arrest is responsible for more than 60% of cardiac deaths. And 1/3 of MIs, they die before reaching the hospital. And most of these patients have a presenting rhythm of ventricular fibrillation or pulseless ventricular tachycardia. And the only effective treatment for these arrhythmias are defibrillation. And when we consider out-of-hospital cardiac arrest, around 8 of every 10 out-of-hospital arrests take place at home. And there is only up to 3 times likely to survival if the patient receives bystander CPR. Now, currently we are teaching lay people to learn bystander CPR. So in the absence of bystander CPR, with each minute's delay, the chance of successful outcome decreased by 10 to 12%. So I guess you understand by looking at this chart that when there is no CPR and when there is delayed defibrillation, the survival is only about 2%, which can increase up to about 30% when you receive effective early CPR and early defibrillation. So that's about the importance of learning resuscitation. So as healthcare workers, it is our duty to learn resuscitation. So in resuscitation, one of the important topics is chain of survival. Interventions that contribute to a successful outcome after a cardiac arrest can be conceptualized as a chain. So this chain is only as strong as its weakest link. All four links of the chain must be strong. So this is the chain. In the first loop, we talk about early recognition and call for help. That is to prevent a cardiac arrest. Second, we go for early CPR to buy time. Then why are we buying time? Buying time to do early defibrillation. That is to restart the heart. Then once we restart the heart, most important aspect is post-resuscitation care. That is to restore the quality of life. So when we talk about early recognition and call for help, out of hospital, in home setup, we have to call for the emergency medical services. Nowadays, it is available 1990 in Sri Lanka. In hospital, we have to identify the deteriorating patient or critical ill patient. And we have to call the resuscitation team, medical emergency team, MED team, that is for prevention of the cardiac arrest. So how can we do this? Prevention of in-hospital cardiac arrest requires staff education, monitoring, recognition of the patient deterioration, a system to call for help, and effective response. We call this chain of prevention. So this chain comprises of education, monitoring, recognition, calling for help, and response. So how do we do this education, monitoring, and recognition? So our healthcare workers, nurses, as well as doctors should be taught about early warning score. This is National Early Warning Score or new score practiced in UK, which is under the NICE guidelines. So they are recommending to monitor physiological parameters such as respiratory rate, saturation, AR on oxygen, systolic blood pressure, heart rate or pulse, and consciousness and the temperature. So by doing the early warning score, we can calculate a number. If the score is 0, patient needs only minimum monitoring, maybe 12 hours. If it is 1 to 4, patient needs at least 4 to 6 hourly monitoring. If the total is 5 or more than 5, or if there is 3 in one parameter, patient needs increased monitoring and referral. And if it is more than 7, patient needs urgent and continuous monitoring with referral to critical care. Patient might need ICU bed, level 2 or level 3 ICU bed. So, how are we going to recognize these patients' deterioration? For that, we teach a very simple method. We call it ABCDE. A is for airway, B breathing, C circulation, D disability, E exposure. So when we monitor the airway, if the patient can talk to you, then we are happy that the airway is patent. But patient looks critically ill and we will put oxygen on the patient, preferably highest flow rate available, 15 liters per minute. Breathing, so you have to examine the lungs, respiratory rate, where the trachea is, chest wall movements, chest percussion, lung auscultation. And at the end, we have to check saturation of the patient. And if needed, you have to suck out secretions. And if you are depending on the finding, you have to act. If it is a pneumothorax, you have to do a needle decompression. So this is how you manage the airway in head tilt and pen lift maneuvers. In circulation, you have to again go through from the basics, from the periphery, skin color, capillary refill time, pulse, heart rate, blood pressure, cardiac auscultation, if available echocardiography, and ECG monitoring. At the end of C, we want a definite IV access and an infusion just to keep the line patent. But if you have found out a lower blood pressure and if you suspect hypokalemia, bleeding, you have to give blood or fluid or blood products. Then D is for disability. A simple method we use is AVPU, alert, voice responsive, pain responsive, or unresponsive. Advanced method could be a Glasgow Coma scale and pupillary reflexes. At the end, we have to check the blood sugar as well. So depending on your disability score, you might have to take a decision. If the patient is unable to maintain airway, if the patient is unresponsive, you might have to think of airway protection. And E is for exposure, maintaining patient's privacy. You have to expose the patient and find out whether there are anything that you have missed. What is the skin color? Is there any rashes, any bleeding points? And at the end, you have to take the temperature. So This is a simple method that we all can implement in our ward setup. So at the end of your assessment, what are you going to do? Now you have to call for help. How are you going to call for help? It has to be structured. So a method that is taught in our European Resuscitation Council is SBAR or RSVP. So you can talk to your senior with situation, background, assessment and recommendation, or reason, story, vital signs and plan. So the person who is listening to your story get a very clear idea about the picture. Right. So now we have gone through how to uh, identify a deteriorating patient or prevention aspect of a cardiac arrest. But if a cardiac arrest takes place, then what is a cardiac arrest? What do we mean by a cardiac arrest? When heart stops pumping, the victim stops breathing as well as um, circulation. So patient becomes unconscious, unresponsive and not breathing normally. Patients are in cardiac arrest. So in management of cardiac arrest, we go through and we have a ALS advanced life support algorithm. This may not be very clear. We will be going through each and every aspect. So before attending to a patient in cardiac arrest, what should we do? We have to assure our safety first. So before approaching this unresponsive patient, make sure that rescuers are safe. So make sure there aren't any dangers like fire, electricity, and make sure that you are wearing a proper personal protective equipment. It is recommended to use gloves, mask, apron to any cardiac arrest. The picture in the right is what we usually use in any cardiac arrest. But this is what we recommend now in COVID-19 cardiac arrest resuscitation. Right. Then how are you going to confirm cardiac arrest? First, we have to assess the response of the patient. You can shake the patient by shoulders, hold to the patient, see whether the patient is responding. If not, you have to open up the airway, head tilt, chin lift maneuvers, and look, listen, feel to check whether there is normal breathing and assess for circulation, check the carotid pulse. So all these things don't take more than 10 seconds, right? Within 10 seconds, we have to confirm a cardiac. Now, if the patient is unresponsive and not breathing normally and you have confirmed the cardiac arrest, what is the next step? Next step is to call for help. Call the resuscitation team, whatever team available in the hospital. Right. So, in basic life support, when advanced life support equipments are not available, even at home, basic life support is recommended. So, how are we going to do basic life support? Main thing is cardiac compression. We have to give effective cardiac compressions with minimal interruptions. Where do we place our hand? In the middle of the lower half of the sternum, and we have to push hard, compressing 5 to 6 centimeters. And we have to push fast, 100 to 120 beats per minute. And we have to allow the chest to recoil, to allow the venous return to take place. So our compression rate is 30 to 2 rescue breaths. The rescue breaths are also given within 5 seconds. So interruptions are minimum. So when we are giving cardiac compressions, make sure your positioning is aligned in this way that you have to be perpendicular to the chest. So chest compressions to ventilation rate is 30 to 2. We can do as a 1% or 2% technique, allowing less than 5 seconds for the 2 breaths. And if you have more than one rescuer, always it is recommended to change rescuers every 2 minutes in CPR because exhaustion is going to give out less effective chest compressions. And we continue chest compression CPR until a defibrillator is available. Now, if this takes place in the community, we want to look for an automated external defibrillator. Still, I don't think in our country this is available, but it is recommended if we can have these external defibrillators placed in community setup. Then the person who is giving CPR or a nearby person can bring this automated external defibrillator and attach to the patient, and that itself will give the command how to proceed. Now, when the defibrillator is available, next step is to analyze the rhythm. To analyze the rhythm, we have to stop compressions. So, analyzing the rhythm should take place within 5 seconds. So if we go through that same advanced life support algorithm again, we have to assess the rhythm and then see what type of a rhythm we are dealing with. Is it shockable or non-shockable? Then we have two pathways, shockable pathway and non-shockable pathway. So in shockable pathway, we are talking about two shockable rhythms, ventricular fibrillation, which is a bizarre irregular waveform with no recognizable QRS complexes, and the patient is having coarse or fine patterns, and it could be having uncoordinated electrical activity. And this patient is in cardiac arrest, so it's a shockable rhythm. Pulseless VT, when there is no pulse, but there is a ventricular tachycardia, which is a rapid regular broad QRS complex, which could be monomorphic or polymorphic, which could be a torsades-pointis. So in that type of scenario, we have to go for a shock. So what is the shock we are going to deliver and how are we going to proceed? So when we talk about manual defibrillation, CPR should be continued until the defibrillator is retrieved and pads are applied. So our country, we sometimes don't have the adhesive pads, then we will be using the paddles. And we have to give the shock as early as possible. So in hospital cardiac arrest, the resuscitation should take place and the first shock should be delivered if it is a shockable rhythm within 3 minutes according to the guidelines. So that is the level that we have to achieve. So delivering shocks with minimal interruptions to chest compression and minimize the pre-shock and post-shock pause. This is by coordinating our activities. So resuscitation is done by a team. So we have to coordinate the activities to minimize the pre-shock and post-shock pause. And it is achieved by continuing chest compressions during the defibrillator is charging. While we are charging, we continue the CPR. And delivering defibrillation with an interruption in chest compressions of less than 5 seconds and immediately resume chest compressions. So this is the current recommendation in manual defibrillation. This is not the machine which is available to us, but what we have is also something similar. And we have to talk about safe and effective defibrillation. When we are delivering defibrillation, it has to be safe because we are handling oxygen at the same time. So we have to minimize the risk of fire. We have to take off oxygen mask or nasal cannula and at least 1 meter away from the patient. And if the patient is on a definitive airway and a ventilator circuit, that can be remain attached. And the pad positions, the first choice, initial pad position is anterolateral position. And ensure the apical pad is positioned correctly at the mid-axillary line, at the level with the V6 pad position, below the armpit. If the patient is having any implantable devices, you can place it about 8 centimeters away or use an alternative position. In defibrillation, the energy levels are not changed. We are starting off with 150 joules as the first shock in biphasic waveforms. And use single shocks where indicated at the end of 2 minute cycles. So in a shockable pathway, when we assess the rhythm and when it is shockable, we restart cardiopulmonary resuscitation, charge the machine. Once it is charged, we ask them to get the oxygen away. Everyone else should be away for safety reasons. And when everyone is away, within 5 seconds, we deliver the shock after again checking the rhythm, whether it is VF or pulseless VT, and then resume cardiac CPR immediately. And we continue for 2 minutes. We don't stop. After 2 minutes only, we check again what the rhythm is. In that rhythm check, if it is again VT or VF, we have to shock. Then the second and subsequent shocks are the maximum that machine can deliver. And if this takes place in a very if the cardiac arrest takes place at a cardiac catheter center or high dependence area where you witness the cardiac arrest, where you have witnessed the VF or VT, you can give 3 stacked shocks. And if the patient is having a refractory VF, you have to think about an alternative defibrillation pad position like anterior posterior. Now, we talked about the shockable pathway in a advanced life support algorithm. Other pathway is non-shockable. So First, when we are assessing the rhythm, if you see a flat line or just P waves, it is asystole. And if you see an electrical rhythm but no pulse, it's a pulseless electrical activity. So in this pathway, our management is giving drugs, that is IV adrenaline, 1 milligram, 1 in 10,000. So let's talk about the airway and ventilation. During CPR, start with basic airway techniques and progress stepwise according to the skills of the rescuer until effective ventilation is achieved. If an advanced airway is required, only rescuers with high tracheal intubation success rate should be using the tracheal intubation, because if you stop CPR for tracheal intubation, you are interrupting CPR. So current recommendation is not to interrupt CPR. We have to continue effective CPR. The expert consensus is that high success rate is over 90% within two attempts of intubation. So expert airway technique people like anesthetist or ICU consultant or ICU registrar, or if it is a trained airway person, can go for tracheal intubation. If not, we can still achieve oxygenation by oropharyngeal airway and bag mask valve ventilation. Oral laryngeal mask airway. So we can use those methods to deliver oxygen. Delivering oxygen is the important thing, not tracheal intubation. And you can use direct or video laryngoscopy for tracheal intubation. In airway handling, waveform capnography is recommended to confirm the tracheal tube position. Capnograph is where you can see the expired carbon dioxide as a waveform, and it gives the feasible. It gives us a lot of information. It gives each breath over. Now, when we give CPR, whether CPR is effective or not is also seen by the value of the capnograph. If the capnograph level is more than 14 millimeters mercury, then we know we are giving a good CPR. And by confirming tracheal intubation, confirming the value of capnograph, so it is important. I know it is not available in every ward setup, but if you have it, please use it. And when we are ventilating a patient, give a breath over 1 second to achieve a visible chest rise. And the rate of ventilation is 10 breaths per minute. Once we have a definitive airway, we do not have to stop cardiac compression to deliver breaths. If you experience with subglottic airways, if you experience gas leakage, then you can pause compressions in the same way as 30:2 compression ventilation ratio. That is only if you experience a gas leakage. So we have to talk about the drugs and fluids in resuscitation. Now, in shockable pathway, we said that we are giving adrenaline 1 milligram if we see asystole or pulseless electrical activity. So to give a drug, we need IV access. So first attempt is to get intravenous access. But if we can't get intravenous access, we have to consider intraosseous access. Then IV fluids are recommended if you think hypovolemia is a cause for cardiac arrest. Then when we talk about these drugs, adrenaline. So you have to give adrenaline as soon as possible for adult patients in cardiac arrest with a non-shockable rhythm. And give adrenaline IV or after the third shock in shockable pathway. And you can repeat adrenaline when you have started in the algorithm every 3 to 5 minutes because it has a short half-life. So about antiarrhythmic drugs in resuscitation, in shockable pathway, we can go up to, the patient can have a shockable rhythm, and if we go on having a shockable rhythm for 3 cycles, after the third shock, it is recommended to give amiodarone 300 milligrams. For those who are having a shockable rhythm, VF or pulseless PT. And if the patient is persistent to have a shockable rhythm, after the 5th shock, you can give 150 milligram of IV amiodarone. Alternative drug is lignocaine 100 milligram after 3rd shock and 50 milligram after the 5th shock. So do we have a place for thrombolytics in resuscitation? Yes, because if we are suspecting pulmonary embolism as the cause for cardiac arrest, you have to consider giving thrombolytics. But if you give thrombolytics, you have to remember that resuscitation should continue at least 60 to 90 minutes. So it's a prolonged resuscitation. So about the capnograph, I have spoken, and usually in cardiac arrest, the usual capnograph value we know is 30 to 40 in normal individuals who are ventilated. But in cardiac arrest, I said if you are having adequate resuscitation, you will see a value more than 40. But if you see a sudden rise in ETCO2, that's a marker to indicate that patient may have gained ROS, return of spontaneous circulation. So this is a new development, use of ultrasound imaging during advanced life support. So only skilled operators should use intra-arrest point-of-care ultrasound. This is useful to diagnose treatable causes such as cardiac campanale and pneumothorax. Right ventricular dilatation in isolation during cardiac arrest should not be used to diagnose massive pulmonary embolism, because in a cardiac arrest, the venous return will eventually cause a right ventricular dilatation. So don't use focus for assessing contractility of the myocardium as a sole indicator for terminating CPR. So ultrasound in CPR should be only done by a skillful person, only cipisternal weave, subcostal weave, and images are obtained during rhythm checks. So rhythm checks takes only 5 seconds, like, so they record, take to another place and see whether the recording. And remember, you can't interrupt CPR because of ultrasound. So what is the place for mechanical chest compression devices? I think there was a talk about these devices during previous corona season. So these things are very handy sometimes. Consider mechanical chest compressions only if high quality manual chest compression is not practical, like a prolonged CPR, or in transport, which compromises provider safety. When a mechanical chest compression device is used, minimal interruptions to chest compression during device use should be only handled by a person who is familiar with that device. So these are useful devices if we can have it. Then another development is extracorporeal CPR. This is considered as a rescue therapy only in selected patients with cardiac arrest, where we want to facilitate specific interventions such as PCI, pulmonary thrombectomy, or when the patient needs rewarming after hypothermic cardiac arrest. So these are only available in special hospitals where ECMO facility is available. So I have spoken to you regarding the advanced life support. I want to ensure that during CPR, we have to ensure the high quality chest compression. This is the most important thing. This is what gives the oxygen to the brain. So that circulates the remaining oxygen in blood to brain. So high quality chest compressions with minimal interruptions is recommended. And give oxygen. Use waveform capnography. Continuous compressions should be continued when advanced airway such as endotracheal tube or LMA is placed. And need to have vascular access, preferably intravenous. If you can't, don't delay going for intraosseous. Give adrenaline every 3 to 5 minutes if you are in non-shockable pathway. And give amiodarone after the third shock. So in the shockable pathway, after the third shock, you have to give amiodarone 300 milligram as well as adrenaline 1 milligram. Right. What causes a cardiac arrest? So there are several causes. We call them reversible and irreversible causes. So reversible causes are the ones that are important for us. There is a mnemonic cause called 4Hs and 4Ts. So if you resuscitate your patient, you have 2 minutes to go through these courses. In every cycle, we are continuing CPR for 2 minutes. During that period, you have to go through these 4Hs and 4Ts. Hypoxia kills first, so look at hypoxia. So ensure that you are giving 15 liters of oxygen to the patient. And metabolic causes, hypokalemia, hyperkalemia, metabolic acidosis, hypoglycemia. So you need a blood gas to check for those. And hypovolemia, you might be able to assess, and history might give you clue. Patient may be from trauma, so patient might need massive transfusion protocol activation, blood product transfusion. If not, initially crystalloids. and hypothermia in a drowning patient. So look for these features. And the fourth is, are we dealing with tension pneumothorax? So look at assess the lung, trachea, percussion, check whether you are dealing with a pneumothorax. These are reversible causes. Needle thoracotomy followed by intercostal tube placement is indicated to get the heart back. Otherwise, you are going to continue CPR for it. So the other causes go through the drug chart history. Is the patient exposed to any toxin? Campanelli, you can get an idea about campanelli by doing an echo, like we discussed before, or else if the patient is from cardiac theatre, just after cardiac surgery, trauma patients who have trauma to the chest, so consider cardiac campanelli. If you can't find any of these key causes and patient's history suggestive of comorbids, the patient is a risk of ischemic heart disease, think of myocardial infarctions because that is the first number one cause of cardiac death. And pulmonary embolism comes as another cause of thrombosis. So treat, search or hunt for these causes and treat them. And continue CPR until you have qualified help, or you can hand over to another person, or until victim shows signs of life, or until the team becomes exhausted. What I want to emphasize is that there is no duration limit. And after achieving return of spontaneous circulation, now this is an event that has taken place with a team effort. So you have to do a team debriefing, and you have to complete the notes, and you have to talk to relatives. At the same time, remember every cardiac arrest patient can arrest again unless you stabilize. So to maintain good quality of care, you have to have a good post-resuscitation care. That's why we talk about post-resus care. So in post-resus care, we have to go through this patient from top to bottom. ABCD assessment comes again. So stabilize your patient. Look at the patient's airway. Maintain saturation 94 to 98. If the patient is having a lower Glasgow scale, go for advanced airway. ET tube is preferably inserted at this level. And go for waveform capnography. Have a normocapnia. Ventilate lungs at 10 breaths per minute. Do not hyperventilate. And do that ECG, 12-lead ECG. Obtain reliable IV access. If you need, you have to go for central access. And you have to aim a systolic blood pressure above 100. For that, you might have to give fluids, you might have to start vasopressors, inotropes, and it's preferred to have intra-arterial blood pressure monitoring in these patients. So that is usually done in ICUs. And ensure normal volume. So in these patients, we can talk about a constant temperature management. So 32 to 36 degrees Celsius for more than at least 24 hours with good deep sedation, controlling shivering is done in ICU setup. So if this cardiac arrest take place due to a cardiac cause, you have to talk about pre-perfusion therapy. Then you have to consider PCI. You have to talk to the cardiology team and arrange that. If not, then you have to consider whether it's an intracranial pathology, so you will have to do a CT brain. If you suspect pulmonary embolism, you have to do a CTP. So in detail ICU management of these patients, again, we do targeted temperature management according to the TTM trial. Maintaining temperature at 36 for at least 24 hours has a better outcome. And we have to prevent fever for at least 72 hours. So we maintain normoxia. We don't make patients hypoxic or hyperoxic. And we maintain normocapnia. We do a neuroprotective ventilation after a cardiac arrest. And you have to optimize the hemodynamics, maintain mean arterial pressure more than 65, and maintain a good urine output. We target the lactate less than 2. We always recommend to do echocardiography to assess the cardiac functions. In ICUs, we go for moderate glycemic control. So these patients should have a normal glycemia, but it is a little higher than normal ward setup. We go for 140 to 180 milligrams per deciliter. And if there are seizures, we have to diagnose and treat, do EEG, give sedations and anticonvulsants if patient is fitting, and delay prognostication for at least 72 hours. So we deeply sedate and ventilate these patients, then only we wake them up If they don't wake up, then we consider prognostication after 72 hours. So lastly, I want to talk about secondary prevention. So why did this cardiac arrest take place? You have to consider whether this patient have any inherited disorders, risk factors to manage. Does this patient need in cardiac defibrillator? And you have to follow up and rehab these patients. So this is how we manage an adult person with a cardiac arrest. And when we do it as a team effort. So it's important to have a good communication within the team. Cardiac arrest resuscitation is always successful with good teamwork. So when we talk about good teamwork, non-technical skills and soft skills plays a major role. So situational awareness, team working, leadership, decision making, task management, sticking to the algorithm. So these things matter. And we recommend it as a team, like when shown in this chart. So you can see that it is done by so many people. One person can't achieve a good result from cardiac arrest resuscitation. So there is a team leader who is hands off. Team leader should be having a global perspective, seeing what every other is doing. So demands should be clear, and there should be closed loop communication within this teamwork. And there is a scribe nurse who documents everything with the time. An airway doctor should maintain the airway. Defibrillator person should maintain defibrillation. Drugs and CPR can alternate every 2 minutes. Right. I have spoken to you mainly about the ALS algorithm. Now, to come to the last part of our lecture, in COVID-19 management, this is, I'm talking with regard to the management guidelines given by the Working Committee on Resuscitation of College of Anesthesiologists and Intensivists of Sri Lanka. So they have formulated a guideline which we are practicing locally. So when we talk about COVID-19 resuscitation, there are certain important things for us. One most important thing is that we need to have proper PPE. So what do you mean by this appropriate PPE, and why do you need PPE? Now, in COVID-19, we talk about the disease transmission. So we don't want airborne spread of the infection to the rescuer. So we have to have droplet precaution PPE and airborne precaution PPE. So what do you mean by droplet precaution? Droplets are 5 to 10 microns in diameter. When they come out, they drop to the floor because they are heavy. Airborne less than 5 microns, they are generated in aerosol generating procedures. They can stay in the environment for some time. So in droplet precaution, the rescuer is asked to wear gloves, short-sleeved apron, fluid-resistant surgical mask, and face eye protection, that is a face shield or visor. In airborne precaution, you need at least 2 pairs of gloves, long-sleeved gown, N95 mask, air and face protection, and whatever other local guidelines say. Some people wear head covering, shoe covers as well. So we need to have this appropriate PPE. And what is this aerosol generating procedures that we talk about in cardiac arrest? So in a cardiac arrest, when we resuscitate, we do bag valve mask. Bag mask ventilation causes aerosol generation. Airborne infection can get transmitted. And chest compression can give rise to aerosol generation. Intubation or giving high flow oxygen can cause it. And in our country, because we use defibrillator paddles, though the adhesive pads are not freely available everywhere. So most of the time we use paddles. So that is also considered as an aerosol generating procedure. The non-AGP procedures are automated external defibrillator. And because then the rescuer doesn't have to intervene, rescuer only have to adhere the adhesive pads and visually assessing the patient's consciousness. So they are not aerosol generating. So when we are resuscitating COVID-19 patients, so remember to recognize a cardiac arrest, you can't do look, listen, feel. You can't go and keep your face next to patient's mouth or nose. So we have to be at a distance. We have to assess visually and don't go and do opening of airways or any airway maneuvers. And it is recommended to cover patients' mouth and nose with a water-resistant cover. And always we need access for PPE. In basic life support, this is the guideline. So It's again, they say to assess the patient and then go through gradually. You have to alert the team that this is a COVID-19 positive cardiac arrest. And when giving rescue breaths, how are we going to do mask ventilation? We need two persons to do this, or we call it four-hand technique. One person to provide the mask seal with two hands, and the other to provide compression and also to give ventilation. So after giving 30 compressions, that same person can give the ventilation. But you have to always put a viral filter between the bag and the mask. And if we are having less skillful staff at the cardiac arrest management, then we only recommend to give oxygen via a face mask and to continue compression only CPR. So there could be delays in starting chest compressions because wearing PPE take time, but staff safety is the paramount important in this scenario. So do not proceed with chest compression or airway intervention without airborne precaution PPE, which requires an N95 mask. So this is again the algorithm, maybe not clear in short. So I will go through the important aspects. In a adult cardiac arrest with COVID-19 inside the hospital, you have to assess the breathing. If we have a defibrillator available, so initial part can be done by the person who is wearing droplet precaution PPE. Initial resuscitation part can be done by the person who is wearing droplet precaution PPE. So the person who is wearing full PPE, long sleeve gown, N95 head cover, everything take time. So if there is a runner or a nurse available wearing just droplet precaution PPE, that person can go and attach the defibrillator pads and deliver a shock if it's a pulse, if it's a pulseless VT or VM, if it's a shockable rhythm. So to start chest compressions, you need airborne precaution PPE. And if the rhythm is continued to be shockable, you can continue to give up to 2 more shocks. Inside the room or bedside, we have to restrict the number of staff available, and they have to keep at a distance. So we need a gatekeeper in this type of scenario to give what we need inside. And do not, if the patient is, if it takes time to get back mask ventilation, you can just put an oxygen mask and give oxygen rather than giving back mask ventilation. And in this type of scenario, if it is going to be a prolonged CPR, mechanical chest compression with mechanical chest compression machines is advisable. And remember to use viral filters between the bag and the airway. If you have intubated or put a laryngeal mask airway, so you have to put a viral filter in between. For intubation, you can use a video laryngoscopy because the visualization is very difficult when you wear all these PPE. And it is also mentioned to stop CPR early if a treatable reversible cause is not found. And ensure removal of this PPE. Doffing has to be done carefully, not to get staff contaminated. So self-contamination takes place when you are not careful in doffing or removing your PPE. So staff is, it is important for the staff to remember that you have to take time and do your doffing. Once everything is done, you have to do a team drill. That is always recommended in any cardiac arrest. So in summary, I have spoken to you about the chain of survival, how to recognize a deteriorating patient to prevent a cardiac arrest, to give early CPR, to buy time, to do defibrillation, to restart the heart, to do post-resuscitation care to achieve a good quality of life after the cardiac arrest, and how communication is very important in this teamwork. And finally, I have touched upon the COVID-19 resuscitation. I acknowledge my teacher, Dr. Mitraji Premaratna, who is the chairperson in Working Committee on Resuscitation in College of Anesthesiologists and Intensivist of Sri Lanka. Thank you very much.
Let's leave the open for question. And question is.
very much for the very what is availability of viral figures, see, COVID patients.
Yes, we have it. The director of the hospital have mentioned to us that they have. Currently, I think they are issuing to the theaters, but if you ask, you can also get. We have it in the hospital. We use for every patient in the ICU.
Thank you.
The absence of any other questions, I think I just some announcement. So we are continuing our series. That's number one. Number two, that people who cannot come here, they can join us through our employed. All the KSM members are getting an email the program conducted by KSM. Please link, and these lectures are recorded. The permission of the speaker, if we are now uploading to our KSM and Facebook as well as YouTube, you can listen even later. Even now. Third one, actually, I know question will be after the discussion. The people who are not yet become a member of the KSM, please be a member, and you will have more advantage, and also to support us by the t-shirt and the tie of KSM, share symbol, and of KSM. Now, with that, I think I will conclude with and thanking the Buddhini for being very informative, helping us, all of us to get updated about the current PPR and the latest information regarding the COVID. That's very important. And then, Teresa, I will hand over the certificate of